So we have Dr. Ron Gharbo in the plane today, and Dr. Gharbo is a specialist in helping people with pain management, among other things. So here's Ingalls Field, straight ahead, sitting on top of one of the peaks in Appalachia.
But we're coming in perpendicular?
That's true. We will do what's called a traffic pattern. Well, we're first perpendicular and then parallel, and then we land.
Excellent.
You're in good hands.
Like the pine trees lining the winding road, I've got a name, I've got a name. Like the singing bird and the croaking toad, I've got a name, I've got a name. And I carry it with me like my...
Now, when we were taking off on that runway, you said your fight or flight response kind of kicked in.
Sure did.
And you had to sort of consciously think about how to overcome it.
Absolutely. I mean, this is clearly riskier than sitting on my couch at home. But I watched you do all the check.
I'm glad you had all those techniques to kind of, calm yourself down. One of the things I rely on my passengers to do always when I'm departing is to make sure that both tanks are filled with fuel. So did you check the tanks and how are you doing on that?
I think we should head back.
So why do we have so much opioids in circulation in this country?
So around 2012, opioids were the #1 cause of preventable death and the surpassed motor vehicle collisions. And 60% of those were prescription medications. There's one young man that I worked with that sort of drives me. He came to me 6 or 7 years ago, and he had a very supportive family. The mother was a nurse practitioner in our health system. All the supportive resources in the world with a back problem. He ended up going to a world-renowned institute and had a back surgery that you can argue shouldn't have been done. And he awoke in this, post-operatively, in this hyper-vigilant state. And there was the opioids that were started by a well-intentioned primary care physician, were then escalated. He has a pain pump post-operatively where he could tap it a couple times per nursing shift, and he was hitting it hundreds of times per session. He just couldn't break free. And he was discharged from the hospital to my care, and I remember seeing him the day after Christmas several years ago, and this was a young, oversedated young man. This is a very supportive family with resources, healthcare knowledge, and later there was a tragic outcome. This can touch anybody. We should have an answer for that. But when it comes to pain management in the United States, we are orders of magnitude more expensive than any other industrialized nation. And we can't prove that we're better than any other industrialized nation. In the late 90s, there was this notion that we were going to stamp out pain based on subjective parameters, what the patients told us. And that's where a patient could say their pain is anywhere between 0 and 5. When you're looking at a patient that is suffering and desperate, the world-renowned institutions with their addictionologists and their pain management specialists were saying it was okay to escalate these dosages to extremely high levels that ignored risk and science, and the pressure was immense.
Let's do a hypothetical. Assume I come to see you because I have terrible back pain. Well, I'm interested in knowing how a typical physician would address my terrible back pain when it comes to, prescribed medication versus what you would do.
You have to create trust. You have to create that this is an environment that you're not going to be judged, that it's a healing environment. So, but it has to be much more than that. So we have to develop trust so that, again, so they'll tell us what their fears are. And the biggest misperception is when these emotional suffering, anxious patients arrive to the clinic and they become desperate for these pain medicines is they're not craving euphoria. They've been prescribed a medicine that for the first time gave them some relief. And they've been prescribed these medicines that work for a few hours and then it goes away. So what they fear, and this is documented for decades, they fear future pain, they fear future movement, they fear future injury, they fear those opioid receptors going empty in 3 hours. So now I can give you an example of a lady, let's just use the name Cindy. She came to me with psoriatic arthritis, and she seemed helpless and hopeless, like many chronic pain patients come to us. And her quote on the first visit was, her brain never turns off. And that's the kind of thing I hear. I hear, my brain never takes a vacation. I call it the racing brain.
And it's racing because it's afraid.
Because it's afraid.
It's afraid that someday I'm going to run out of this medicine, the pain's going to come back, how am I going to deal with this? And they basically get trapped in this cycle of thinking.
They are exactly trapped. So opioids are not evil. It comes from a flower. How can a flower inherently be good or evil? They're used or misused. And I'm contemplating giving you this patch to cover these opioids. The nice thing about these
receptors... And by patch, you mean a literal patch that regulates the amount of opioid release in your body over a period of time.
Right. So it's only going to do it partially. And the good news is they're not going to go empty. It's going to be in your system when you wake up. It's not going to cover all your pain. It's safer than most other opioids. Now, in return, I'm going to ask you to do this breathing 10 minutes twice a day and as needed. And I'm going to check your compliance. And you're
and that's the breathing to calm down and get out of the racing brain.
Yes. So the method's called stop, shift, and decide. So stop the racing brain with these breathing techniques, deprive it of its fuel, shift emotion. And so if you have cancer, so a typical cancer patient that I may see is afraid of death, future pain, future loss of dignity, future financial destitution, fear of leaving people. But if you are, today you're going to spend it with your grandchild, all those 5 fears I just listed are very valid. If you are able to shift and feel gratitude today with this grandchild, that you still need the medicines, you still need the radiation, you still need the chemo, but it will improve your surveillance of cancer cells. It will take away some of your amplified pain. So getting back to Cindy, who had back pain, she also had panic attacks, and where she was at a Walmart and there was a thunderstorm, and she used the breathing techniques, and she got through a panic attack. And that was one of her turning points.
So what you're saying is this more responsible, regulated usage of the drug combined with training for the patient to sort of stop that counterproductive racing brain cycle that you talked about actually has a better outcome?
That's the start. So Cindy, she was being prescribed 90 pills, and then she was also getting 30, 40 pills for anxiety. So that total number is reduced to 20 or less. That tells me that 10 days a month minimum, she's not using anything. And that's a critical threshold that I know. She's lost 24 pounds, but 2 weeks ago she told us she had quit smoking 5 days earlier.
Wow.
This is how people's lives start to improve. She's transforming. When she is this person, she will recognize, and it'll be a different person from the anxious, irritable person that we met last April. We have what we call a welcome back moment. And it's usually with a handshake or a hug, and we welcome them back to who they really are, and that's a special moment.
The wind, 200 at 6, runway 21, clear to land.
Clear to land, 17 Mike Echo, thank you.
I'm sitting in the railway station, got a ticket for my destination. On a tour of one night night stands my suitcase and guitar in hand, and every stop is neatly planned for a poet and a one-man